was kind of difficult for me to organize something to give you some idea about that. And if I'm a little bit not really structured, I apologize ahead of the talk. But then I decided that main goal would be to give you the basic understanding that cancers differ, although it's in head and neck, but they differ. Because a lot of times people come to my clinic and they say, okay, my uncle had a neck cancer. You know, to be absolutely honest, if we go into details of head and neck cancer does not mean anything. Because, hello? Yeah, because if we're talking about neck per se, usually cancers in the neck came there from somewhere, primary somewhere else. So, and thinking about that, definitely we need to talk about anatomy. And that's how we divide our area of expertise. Face as a skin, oral cavity, and including lips, our cheeks, and inside buccal mucosa, our tongue in the oral cavity, but not all the tongue, 2/3, anterior 2/3. The back goes a little bit different area. Then hard palate as well. Then we have oropharynx. Oropharynx includes soft palate and uvula. It's a little thing, you know, when you look into the mirror, it's right in the middle of the throat on the back. Our tonsils and posterior third of our tongue, so-called base of tongue, which is really heavy in lymphoid tissue, and that's why it behaves a little bit different if it gets diseased. Then we have hypopharynx. It's basically, if we translate it, it's a lower portion of our throat. It's a very interesting area, very difficult to treat, and cancer behaves differently from, for example, oral cavity or oropharynx. Then we have larynx, which is our voice box, which also divided into supraglottic, glottic larynx, and glottic larynx is our vocal cords. And do you have a laser point by the chance? I'll try to navigate with a little arrow if you see that. Yeah, so supraglottic larynx would be at the top of the voice box, and glottic larynx would be just vocal cords, what we have. And then definitely in head and neck, we have our sinuses, which could be the source or kind of base for the cancer as well. And we have nasopharynx. Nasopharynx is basically what kids usually have adenoids, and that's our nasopharynx, right on the back of our nose in that area. In all those areas we can have cancer, as well as in our ear, in our thyroid gland, which is right below right here. But today we won't talk about any malignancies of the ear or thyroid gland because it's pretty much a totally different topic, and we probably need to gather a little bit later to talk about that. So it is very important to distinguish those cancers in the different areas because, as I said, behavior is different, treatment is different, approach in general different. And talking about approaches, by convention, we have single modality approach and multimodality approach. Single modality, it's either we choose surgery or radiation or chemotherapy. Chemotherapy is a little bit tricky because usually it's used as a single modality for lymphomas, nothing else. Usually chemotherapy is used as a part of multimodality treatment, as a help to radiation or help to prepare patient for surgery. When we talk about surgery, it's really nice, really quick, clean cuts, easy to evaluate margins if we excise all the cancer. But at the same time, it can be pretty dismantling because sometimes if we're talking about big cancers, if we go with the surgery as a primary modality, it can be pretty disfiguring, cosmetically and functionally wise. Also, if we're talking about surgery, definitely general anesthesia is kind of part of a risk. If we're talking about radiation, which can be used as a primary modality or a single modality treatment, or primary treatment for certain cancers like true vocal cords cancers. It's also nice, but you always have to think what can be done wrong with that. And as well as with surgery, with radiation, downside of it is lengthy treatment. We're talking about usually 7 weeks of treatment every day, like 5 days a week for 7 days. Afterwards, you can have some burning to the skin on the neck, or if we're talking about radiation to the other different other tumors, it could be difficult to kill all the cancer because of a size of a tumor or location of the tumor. Definitely, technology is coming up with new types of radiation treatment, not just old conventional radiation treatment when they blast from A to B, everything what's in between. And people have terrible results in terms of functionality afterwards. Right now, for example, IMRT, intense modulated radiotherapy. Very nice when cancer is approached from different angles with the radio beam. And it spares all the healthy tissues around the tumor, but concentrates on the tumor, killing the tumor. But still, you have different side effects. Majority of my patients complaining of dry mouth, and it's really significant problem for everybody after radiotherapy, because radiotherapy kills salivary glands, and that's when you become kind of dependent on a bottle of water with you. Chemotherapy, as I said, as a primary modality used for lymphoma, but usually is done with conjunction with radiotherapy. And unfortunately, when you combine those two, although effectiveness is high, studies have proven that combination of radiation and chemotherapy improves survival by 20%, but side effects also get more severe. And majority of patients complain of severe burning in the throat due to mucositis, so-called. It's like chemical burn of the lining of your throat and your mouth. Usually people have difficulty swallowing, inability to swallow. Sometimes they get dependent on a G-tube for a prolonged period of time because they cannot swallow. And a lot of times, due to that severe burn inflammation, people end up with so-called stricture of esophagus. So our food pipe gets scarred to the point that they cannot swallow. So with every treatment, there are pluses and minuses, pros and cons. So, and if somebody has a discussion with the physician about what should I do, it's always you have to remember or push this thought to somebody, saying, well, you have to think about all the aspects of the treatment. And that's the main idea after this talk. You cannot really, if God forbid something like that happens to somebody they cannot approach the topic of treatment just from one angle. They always have to approach it from different angles, think about all kinds of possibilities. If they're talking to a physician, they have to ask, what are the pros, what are the cons, what should I expect in details? And don't be afraid to ask physician many times the same question. Because sometimes physicians give you just general information, okay, because that's what we're trying to achieve, kind of forgetting what we don't want to see. It's sort of like a psychological effect to a certain extent. So ask physician the same question many times, so we can discuss it. And I'm absolutely happy to discuss it with anybody. So talking about head and neck. Skin cancers. It's starting from outside, going inside. You heard many times that somebody has a skin cancer. What does it mean? There are different skin cancers we have. Most common one is so-called basal cell carcinoma. It's the most common cancer for that part of the head, usually upper lip and above. It's really rare for lower portion of the face. The second most common is squamous cell carcinoma, which is most common for lower portion of our face, lower lips. It definitely can happen on the upper lips and the upper face as well, but usually it's lower third of our face. And the third most common one is melanoma. Melanoma is a little bit tricky one. It doesn't really behave like previous two, and it's more unpredictable and more aggressive. So on these pictures, for example, picture right here, this typical presentation of basal cell carcinoma of upper lip. There are different types of basal cell carcinoma, but majority of them behave absolutely not exactly benign, but not very aggressive. They can become locally aggressive, but usually do not metastasize. And the primary modality of treatment for that is just simple excision. And sometimes it's possible to excise it with really relatively close margins, about like 5 millimeters, which is about 1/8 of an inch, something like that, right? So around the tumor. And for example, this one, so-called T1, basal cell carcinoma of the upper lip, it would be excised and reconstructed with a primary closure with no difficulty. You know, after a patient heals out, after something like that, yeah, you can barely see that something happened. Squamous cell carcinoma. Right here you can see its typical presentation of lower lip. This one I would call T1, T2. So basically T1, T2, T3, T4. That's how we grade our cancers in head and neck. It's based on size. And small ones, T1, 2 centimeters, T2, 4 centimeters, T3, more than 4 centimeters, 6 centimeters, T4. As well as certain areas of involvement, but I wouldn't really go in there because it's like separate topic again. So with this low lip squamous cell carcinoma, I would say it's about T2. Primary modality would be excision as well. Some people can choose radiation, but I would recommend not to do that because you're asking for more side effects or more negative result of the treatment than the positive. These can be excised, and again, with primary closure or certain advancement of this surrounding tissue, and usually people doing absolutely fine. Initially, if people use dentures, there is some difficulty putting dentures in, but with time, after everything heals nicely, oral cavity stretches, and dentures go in with no difficulty. Lower lip can be resected up to 60% of the length with pretty much primary closure with no reconstructions, and results are pretty good. Squamous cell carcinoma a little bit more aggressive than basal cell carcinoma and has a tendency to metastasize. When it's located on the lower lip, occult metastasis or possibility for metastasis into the lymph nodes in our neck. Do you remember I said, you know, cancer comes to the neck from somewhere? That's so-called regional metastases. So about 10%. That's why we usually do primary excision of carcinomas like that, and we don't do really anything else. We just follow people with regular meetings, checking the neck, making sure that nothing is popping out there. So, in the right lower corner, typical presentation of melanoma. And as I said, melanoma is totally different from other cancers because when we grade majority of our head and neck cancers by T1, T2, T3, because of the size, melanoma is graded by the depth. And it's very important to remember because we'll talk about that a little bit later.